Welcome to Thursday National Thrombosis Week virtual conference. This morning, it's my great pleasure to welcome Professor Roopen Arya to this conference to discuss a patient information session around recovery after diagnosis of a blood clot. Professor Roopen Arya is a clinical director of the hematological medicine at King's College Hospital and also consultant in thrombosis and hemostasis there. And he's also the director of the VT Exemplar Centre network across England. He's a huge supporter of Thrombosis UK, and we feel really privileged to welcome him here today. Please get ready with your questions. After a brief sort of discussion and presentation, I know Roopen will be very willing to take questions. If you pop them into the Q&A, which is in the toolbar, we'll be able to see them and then do our best to answer as many as possible. We also welcome here today Claire Prince from Thrombosis UK, who will be also joining in the discussion and the questions after the presentation. But for now, I'm going to pass over to Roopen and say thank you so much for joining today, and we look forward to hearing from you.
Thanks, Jo. Good morning, everyone, and welcome to this session during National Thrombosis Week. Thank you to Thrombosis UK for organizing this and giving me a platform to speak to you. So thanks, Jo, and thanks, Claire, who are here from Thrombosis UK today. Some of what I say might overlap with what my nurse consultant colleague Emma G might have mentioned yesterday, but that's probably not a bad thing. So basically, my topic is returning to everyday activities after a blood clot. So what happens after you're diagnosed with a blood clot, be it a deep vein thrombosis, usually in the leg, or pulmonary embolism in the lungs, and really, getting over the shock of a new diagnosis. Often in younger people, this is the first health problem they've ever had, and it comes as a big shock. And if you start kind of Googling blood clots, you come up with a lot of very variable and sometimes worrying information. And then I think getting accustomed to the diagnosis and to the treatment, and there's the fear of the unknown and anxiety about what comes next, and what is my body telling me? Is this meant to be hurting, or do I have a new clot? So I think it can be quite a challenging kind of journey as a patient. And of course then there's an amount of variability in the healthcare system as to the kind of amount of expertise that is available. But deep vein thrombosis and pulmonary embolism are very common kind of cardiovascular conditions. So the NHS should generally be well equipped to deal and advise. So really, I will briefly cover the pathway, from diagnosis to treatment to follow-up, and then the long term, because really many questions come to mind. Now, most patients have DVT diagnosed in an outpatient setting, with kind of ambulatory care models, either based in hematology or in ED or in a same-day emergency care unit, where generally they might do some blood tests, including the D-dimer blood test, which is the D-dimer is the smallest kind of chemical breakdown product of a blood clot. So you can combine the D-dimer with a kind of scoring system that helps you decide whether you need a scan or not. And then you would usually have this ultrasound scan of the leg, which helps diagnose deep vein thrombosis, usually quite definitively. Pulmonary embolism again, the pathway is getting more and more streamlined, particularly in specialized centers. But often you are admitted to hospital, even if it is for a day or two. So in addition to the blood tests and a clinical probability scoring system, the main test we use is called a CTPA or CT pulmonary angiography, again, which is a very sensitive test to help make the diagnosis. And then, of course, there are also patients who might be inpatients in the hospital who go on to be diagnosed with deep vein thrombosis or pulmonary embolism, usually, as a consequence of the reason for hospitalization. So really, many questions might come up in this journey, and hopefully patients are provided good quality information and assurance at every step of the journey. So questions might be like, how long will I need anticoagulant treatment? Again, it used to be a very formulaic approach, say 20 or 30 years ago, where 3 to 6 months was seen as the necessary period of anticoagulation. And then after that, people would stop and that would be it. And the end of the medical contact. Now there's increasing individualization of the approach to treatment. And clearly there's many factors, that go into the decision about how long to anticoagulate, including where the clot was, what the risk factors were, how well the treatment is tolerated, and what your personal preference as a patient is for, But the main pivot that is used to determine whether to give 3 or 6 months or to give longer is whether the clot came out of the blue or whether it was provoked by a risk factor. Now, if a clot comes completely out of the blue, you're minding your own business, and suddenly you develop leg swelling or chest pain or breathlessness and are diagnosed to have a venous blood clot. Then, if after the 3 to 6 months the blood thinner is stopped, then the risk of having another blood clot is unfortunately quite high, and usually of the order of about 30% over a 5-year period. If there's a very strong provoking factor, like having major abdominal surgery, for example, from which you are completely recovered, then the risk of recurrence is pretty low, of the order of maybe 1 to 2% a year. Travel-related thrombosis, again, which is something I'll go on to talk about later. Travel is very well publicized, and it's in all the media and the social media as a risk factor for blood clots, but is actually quite a weak risk factor. So generally speaking, if you've had a flight-related clot, we would manage the duration very similarly as if there wasn't a provoking factor, namely an unprovoked blood clot. So again, so this is one of the conditions in which, as far as the recurrence risk goes, being a bloke is not great, in that if you're male as opposed to female, your recurrence risk is at least 2 times greater. Because women often, as you know, are more likely to encounter risk factors like pregnancy or the pill, and can sometimes have their blood clots a bit earlier. Men generally tend to have the clots a bit later in their lives, but then the risk of recurrence is higher than in women. So again, if you are a male with an unprovoked proximal DVT, for example, I mean, as likely as not, you will end up on long-term anticoagulation. So clearly, one of the decisions is what is the best treatment for you when you present with a blood clot. In the vast majority of cases, simple anticoagulation is the best treatment. Because I'm sure many of you are aware that, there can be more interventional things that can be done, in the terms of using clot-busting drugs, both for deep vein thrombosis as well as pulmonary embolism. But by and large, there is no evidence that using those clot-busting drugs is superior to anticoagulation alone in the majority of patients. Clearly, if you have a major blood clot on your lungs, which has put you in a serious position, and you have a low blood pressure and your circulation is compromised, then there's no doubt that clot busting would be the way to go if possible. Similarly, if you have a very, very big and proximal DVT, the so-called big leg can't walk, with the iliofemoral DVT, then, there are options to intervene to either bust the clot or to remove the clot. But again, those more interventional approaches have a risk of their own and often a greater risk of bleeding. And by and large, there's no advantage in terms of better outcomes. That most people will do perfectly okay with anticoagulation. Again, there's, people think, oh, we are being put on blood thinners and, it's flushing away the blood clot. Again, that is not the way it works, in that the body generally heals and dissolves the blood clot, and the blood thinners provide a kind of milieu to help the body heal the blood clot, and at the same time prevent recurrence of the blood clot and extension of the blood clot. So that's why it is not unusual, for example, even years, 5-10 years downstream from a blood clot, if you were to scan the leg, you might see some residual blood clot, because that is quite normal for the way the body heals the blood clot and is not unexpected. And really, it very seldom affects our decision, about how long to treat, which is why we don't keep scanning the leg, to see if the clot has gone away, because we understand that, the blood thinners, the anticoagulants, help the body to resolve and gradually organize the blood clot, and also preventing the clot from extending or from recurring. And often people tend to be very nervous, in the first few weeks after the blood clot, that, oh, should I move around because the blood clot might break and go somewhere else. So again, I think that healing process and the clot getting stuck to the vessel wall, it all occurs within the first few days. So I think the chance of anything worrying happening to you, by and large, if you're on the right blood thinners and if you're taking the blood thinners, is very low. And in the old days, even 20 years ago, the general practice when people had a DVT was to put them in a hospital bed. And in fact, that just made the problem worse, because a very important component of why blood clots happen is a sluggish blood flow, also called stasis. So, which is now why, for example, for DVT, most of the models of care are ambulatory models where you're treated as an outpatient and you go home on usually same day, and you are encouraged to walk about because within hours and days of starting the anticoagulation, the clot is stable, the clot is sticking to the vessel wall, and it's not going to go anywhere. Sometimes people present in the same 1 or 2 day, within presentation, they might have leg pain, and maybe they've had 1 injection of blood thinner, and next morning they have chest pain. So really, that is very much part of the same episode. So generally speaking, for the majority of patients, the main anticoagulant we would be using these days are tablets, and these are called direct oral anticoagulants, and they work by inhibiting one of the main blood clotting factors, which is called factor 10, and it's very, very effective at helping treat the clot and also prevent recurrence and extension of the clot. And again, the main anticoagulants are rivaroxaban, which is taken once a day, apixaban, which is taken twice a day, and edoxaban, which is taken once a day. Each of them have certain characteristics, around how long they last in blood. And with rivaroxaban, you need to take it with food. But they're all pretty effective, and they're all very safe, and they do their job unless you miss taking the tablet. I think one of the advantages of these newer generation of anticoagulants is they work very quickly, but that also comprises a disadvantage in that they wear off very quickly. So you miss a couple of doses and you're completely unprotected, which is why I think it's important to take the tablets. Of course, for 50, 60 years now, the main blood thinner, oral blood thinner we used was warfarin, and warfarin still is very effective and important blood thinner, but we are using it mainly in people with mechanical heart valves, and in which, no doubt, warfarin is still the best blood thinner, and the direct oral anticoagulants are not as good. I mean, the other scenario in which warfarin is again the best blood thinner is in the folk who have antiphospholipid syndrome. Again, antiphospholipid syndrome accounts for maybe 1 in 10 of the blood clots that we see. And generally speaking, if you have strongly positive antiphospholipid syndrome, warfarin is the anticoagulant of choice, though, in a certain subgroup of people who maybe have just 1 out of the 3 antibodies positive, there might still be a role for the direct oral anticoagulants, and they might still be used in that setting. The other kind of area in which sometimes we can see people develop clots or extensions of the clot despite treatment is in people who have cancer-associated blood clots. And for many, many years, low molecular weight heparin injections, whether Clexane or Fragment or even tinzaparin, were the kind of mainstay of treatment of blood clots related to cancer. So I think the evidence now for many of those patients is that direct oral anticoagulants do the job equally well and equally safely. So I think overall, providing you're taking your anticoagulant tablets, the trajectory is quite predictable. Most people do very well. The kind of bleeding risk with these anticoagulants is very low, certainly less than 1 or less than 0.5%. And there is some evidence, that for DVT, for example, that the outcomes might be better than historical outcomes in the long term, Particularly, I will just in a moment mention what the sequelae of blood clots can include, which is post-thrombotic syndrome, and there is some evidence that the outcomes might be better with rivaroxaban. For example, we had done a study at King's a few years ago which showed that. Now, that might be just because it's easier with the newer anticoagulants in that you don't have to monitor them, and providing you take the tablet, the effect is predictable. With warfarin, you need to ensure that it's properly monitored and people have a good time in therapeutic range. So, is that difference because of the drug itself, or is it because you're more likely to be in range all the time with the direct oral anticoagulants, as opposed to with warfarin, where even if you're well controlled, you're in range maybe 75% of the time. So, and generally speaking, bleeding is not a big issue, unless you have some kind of previous risk factors for bleeding, like peptic ulceration or some reasons for mucosal bleeding. I mean, one point that has been mentioned in the other sessions, no doubt, is heavy menstrual bleeding, which clearly in women who are still having periods, if you go on to blood thinners, there's the potential for the periods to be heavier. And it is something we used to see with warfarin as well. And we had ways of getting around it with, a bit of dose reduction early in the periods. But it does seem to be quite a significant problem linked to these direct oral anticoagulants, which do cause more mucosal bleeding. Again, there's ways around it, either using hormonal treatments like the pill to help reduce bleeding, or or tranexamic acid, or often what we would do is we have a kind of questionnaire when the kind of younger women present to the DVT clinic. And if we anticipate that there might be an issue already with heavy menstrual bleeding, because fibroids are very common, about nearly half the women in their 40s and 50s have fibroids, whether they know it or not. So we would perhaps choose the direct oral anticoagulant, which has the better bleeding profile in that setting. For example, apixaban in preference to rivaroxaban in that setting. So, and if it continues to be a problem, then there's always the option of gynae referral. Again, something to mention whilst I'm on the topic is if women are on the pill when they present with DVT, usually, the healthcare folk are in a hurry to maybe they stop the pill immediately, or they stop HRT immediately. Whereas, there's good evidence that if you're taking the blood thinner, that you don't have to do that. You can continue on the pill or on the HRT, and the anticoagulant will protect you from, the effects of the oral estrogens. And of course, when it comes to HRT, we know that the transdermal HRT, which is HRT given through the skin, which now should be the kind of way of delivery of choice, is very safe, even if you had a previous blood clot, and even if you're not taking a blood thinner. That is transdermal HRT in the form of a patch, a gel, or a spray, usually given in combination with a safe progesterone like utrogestan. So again, being aware of time, I'll move on. So the other question you might ask is, when will my clot and the pain and discomfort go away? So again, I think within days of starting the blood thinner, the inflammation associated with the blood clot subsides, and really the pain should settle within days and certainly weeks. There is a well-described phenomenon called post-thrombotic syndrome, which in some shape or form can occur maybe in nearly half the patients after DVT, but in a more severe or significant form occurs in about 1 in 10 patients after DVT, particularly in people who've had blood clots very high up in the leg, very proximal blood clots. So this post-thrombotic syndrome phenomenon is due to the blood clot damaging the blood vessels and the valves, which get a bit leaky, and together with the presence of some scar of the blood clot or obstruction that remains in the vein, and that can result in a combination of leg swelling, kind of redness, often pain, discomfort, and in very severe cases it can end up with leg ulceration. But in the majority of cases, post-DVT, the pain subsides within days. You might, in the months to come, feel the occasional kind of twinge in the calf or in the leg. You might still have some residual swelling that could remain long term, but in the majority of cases, the leg decompresses and goes back to kind of near normal. Now, again, for many, many years, there's a kind of received wisdom that in addition to the blood thinners, what might help to prevent post-thrombotic syndrome was wearing those graduated compression stockings for 2 years after a blood clot. But the more recent studies show that, they looked at 600-700 patients with 2 arms. One arm wore stockings, the other arm didn't. And there really wasn't much difference in the 2 arms. So really, I think some patients still find that the stockings might be of benefit and certainly reduces the swelling while they're wearing them. So really, if a few months down the line, you still feel an occasional discomfort in the leg, that's probably post-thrombotic syndrome. And that particularly if you're taking the blood thinners and taking them reliably, it would be unusual to get a new clot. Again, as with everything in medicine, there are exceptions, and we can go on to discuss them. So the other question is, how soon can I be physically active and get on with normal? Again, it is, I think, very, very individual decision. And I mean, it depends on the effects of the blood clot, how large the blood clot was. And I think it's important, the pre-morbid condition, before you had the blood clot, what were you like? I mean, there are often patients who are athletes or who go to the gym several times a week, and or in older patients who perhaps are not active or who are bedbound. So we are talking about very different scenarios. And I think undoubtedly, because people don't know how much they can or cannot do, there's an element of deconditioning that happens after a DVT or after the pulmonary embolism. This is partly physiological and partly because people don't know, because whoever was looking after them, didn't have the time in a very hurried clinic to counsel them about what they could or could not do. So I think And there's always, particularly in younger folk, this is the first health problem they've ever had in their life. And, they're Googling it and, saying that it's a life-threatening condition and, they're afraid to move even, So there's the deconditioning, there's the anxiety, and of course, potentially the effect, of needing to be on a regular treatment and the potential impact on lifestyle and sports activities. But I think it is very, very much an individual decision about, gradually building up to exercise. Because physiologically, about half the healing of the blood clot takes place in the first few weeks, and then the rest is more gradual. And that is the purpose of giving 3 to 6 months of anticoagulation at the very least. It's to help the clot to heal and also to prevent extension and recurrence. So gradually build up to exercise. And similarly, the workplace, if you are in a high-risk workplace, then I think, there are decisions about, in the long term about what it would be wise to do. So generally speaking, there's the current advice is to be active almost immediately after the blood clot. I mean, there is advice from physiotherapists about, graduated return to normality. Thrombosis UK have got a leaflet on this, and also I think there's something on YouTube that, at the very least you can adhere to what is called the beginner's walking program, with the goal to walk for 30, 40 minutes every day after the blood clot. In the first week, maybe start with 5 minutes several times a day. Week 2, 10 minutes twice a day. Week 3, walk for 15 minutes twice a day, building up, at the end of a month to, 20 or 40 minutes a couple of times a day even. I have more athletic patients who do a lot more, lot earlier on. And again, there are studies that show that that's not going to do you any harm. Similarly, there's less athletic patients who are not very active anyway, and find it more difficult to. And also, there's physiotherapists recommend various exercises because sitting for long periods of time is not particularly good. So ankle pumps, knee extensions, seated marching, again, all the patient information is in the leaflets and it's online, and again, anticoagulants by and large do not restrict your lifestyle, unless, you do kind of sports like rugby or boxing, or if you are an avid skier, so I've had patients who are like professional athletes who've kind of got back to kind of normality. And so really, it's very much an individual decision. There are studies now, both for DVT and for pulmonary embolism, for early exercise treatment supervised by physiotherapists that seem to indicate that you get better outcomes and less post-thrombotic syndrome, for example. And, there's even studies in animals, in mice, for example, where they developed a DVT model and then put the mice through resistance exercise and found that the mice doing the resistance exercise had better outcomes in terms of resolution of the blood clot. Generally, the advice is keep active. Exercise really is very much what you are feel able to deal with, but walking, swimming, cycling, gentle running, kind of aerobic exercises. And then with most people, I think, they approach a kind of normality within weeks and months. And able to go to the gym and gradually build up to the activities they used to do earlier. So again, I think much neglected, I'm kind of winding up this section because I just found out more to say than I'd intended to, is that, for years, I think the focus in all the kind of medical trials was on, outcomes like recurrent blood clots or bleeding, but often neglecting what mattered to the patient. So I think, is it normal to feel anxious or depressed after blood clot? Yes, it is normal, and it is very common. And I think, as a kind of medical establishment, we are getting more and more aware of the need to take a holistic view of caring for patients with blood clots. And in the big kind of thrombosis society, there's a focus on what are called PROMs, or patient-related outcome measures, that measure how much patients are limited. Is there residual pain or breathlessness? What is your quality of life? What is your change in life view? So really, to help improve treatment, we have to focus on that. And thankfully, the powers that be acknowledge that this is an area that we need to address. Again, just now kind of winding up my spiel, a very common question, because people tend to travel so much, is how soon after the DVT or pulmonary embolism can I safely travel? And usually, most of the guidelines would say 2 to 4 weeks. Though that said, there have been patients from Australia who have been in a hurry to get back to Australia and who've traveled even a week after. But generally speaking, about 4 weeks. And, if you're on the blood thinner, then it's going to protect you from any kind of bad things happening. So, okay. So I do have more to say on travel, but I'm aware that there's a lot of questions and chat. So maybe I'll stop at this moment and we can deal with some of the questions, Jo. Yeah.
Thank you, Roopen. That was very informative and comprehensive. And I can see from the chat and the questions provoke lots of comments. Just taking you back, I think, to one of the first questions that came through, but also to the beginning of your talk. And it links in with so much you've said since. The shock of a diagnosis for some people, can really affect them. And then the fear, especially if you experience continued or new pain or breathlessness, about is another clot occurring, even if you're already on anticoagulants or blood thinners. And so David has asked this, but I know others have alluded to it as well, is the hardest ongoing issue they find at the beginning is being able to tell the difference between, say, head pain or leg cramps and worrying if it's another clot. Are there any tips or advice that you could share on this? And we know this is a very common, understandable problem.
Yeah, no, it is very common, and I'm afraid there's no universal panacea. I think for each individual, it's different, and you have got to learn to listen to your body. That generally speaking, the majority of patients' leg decompresses, the discomfort reduces, and even months later, you might get some calf discomfort due to post-thrombotic syndrome, but the swelling has gotten down. So, the time to worry is if you get, severe and persistent symptoms, which might have been similar to the original presentation, so either worsening of the swelling of the leg or a persistent or severe pain. Because generally speaking, in 95% of the patients, you're taking the direct oral anticoagulants, and as long as you're taking them, it does what it says on the tin. And it would be very, very surprising to have a recurrence, unless, for example, you have, something like cancer-associated clot and the cancer has not been picked up. Again, that's very unusual because generally in the DVT clinics, people do screen for any worrying signs or symptoms at the outset, or do further investigations as necessary. So yeah. So I don't think there's one right answer, but from my point of view, you have to listen to what the body is telling you, and from the healthcare professional's point of view, you have to listen to what the patient is telling you. And really, if you're really, really worried, or if the pain is persistent, or you've got new swelling, or the symptoms were similar to how you originally presented, then yes, seek medical attention. And then, to muddy the waters further, even with the medical attention, sometimes we cannot be 100% certain whether there's an acute on chronic clot or whether there's a new clot. So generally, we have to combine the various investigations. There were some scanning departments are good at distinguishing old from new clot. There are some newer imaging methodologies that are not available everywhere that can help you distinguish. And then the D-dimer is often used in combination, which it is a very sensitive test. But again, the D-dimer usually goes down over days and weeks, so it might not always be raised, so you can get a false negative. So yeah, no universal answer, but I think for each individual, they have to learn, to listen to what their body is telling them, whilst knowing that it would be unusual to get a new clot, other than, antiphospholipid syndrome, or, if there were any other risk factors for that. Equally, years ago, there used to be an enthusiasm for testing for thrombophilia, which was a tendency to blood clots. Again, now we probably do 10% of the testing we used to do 10 years ago, because in the majority of patients, it makes absolutely no difference to the treatment. And even in your white patient, it's going to be positive in maybe 30% of patients. In your black patients, it's going to be positive in less than 10%, because the tests were developed in European populations. So I think, yeah, that's a rather long-winded answer.
No, but yes, Claire.
Can I just add, if you want, you can always go on the Thrombosis UK closed group. We do often get lots of people saying, I've got this swelling in my leg. Do a go to A&E, do a go and see it's a new clot. And often quite a lot of us, or quite a lot of people, will jump on and they'll say, right, how long have you had it for? Is it persistent? Possibly go to A&E. And sometimes as a patient, if you're learning to develop what is normal for you and what is new for you, sometimes in order to ease that anxiety, you've got to go and sit in A&E, because if you go and sit in A&E quite a few times and it's not a new clot, you soon quickly learn what is new to go and sit in A&E and what isn't, especially these days with the massive weights that people have got. But as Roopen says, it generally is, if you've got a new clot, generally is persistent pain, persistent breathlessness, persistent swelling, stuff that doesn't go down or doesn't disappear if you rest or you take your mind off it. That's what we always sort of guide patients, and always go and seek advice if you're really worried. And that always helps it as well.
Yeah.
Thank you. Now, another question, challenging area. I'm not sure there's an absolute answer to this at all, but a couple of people have raised it. They get differing types of advice, sometimes from their doctors or their specialist or their physio, and it's trying to make sense of the information they've given or the advice that they've been given, if it contradicts each other, and what they can do when they receive differing advice. How can they manage what they've got and also follow what they think their body is telling them? Are there, maybe there's a start off, the sites to go to for reliable information, or the questions sometimes to ask to try to hone into what is right for you?
Yeah, I think the Thrombosis UK website and app are very, very useful. I think first points of reference. No, because I completely agree. That to a certain extent, it's potluck as to what you get in terms of advice, because GPs are not specialists in post-thrombotic syndrome. And even if you present to different emergency departments, you might get different perspectives. But which is why I think it is helpful to have Thrombosis UK kind of providing the portal, and you also have access to a lot of very expert doctors and nurses and pharmacists, isn't it? So, yeah.
Thank you.
May I answer one question whilst I remember it? So there's a question from Julia Barrett on if you had a hormonally provoked TVT from a transdermal combined contraceptive patch, would it be safe? So transdermal combined contraceptive patch has the same risk as the oral combined contraceptive pill, because it's a different form of estrogen in a higher dose. So whilst on the blood thinners, you could still use that, but when you come off the blood thinners, you'd have to change to an acceptable form of contraception, like the progesterone-only pill or the Mirena coil. But I think the related question, which is what I wanted to pick up, is that transdermal HRT is safe. Transdermal contraceptive patch isn't when it comes to VT risk. And again, we are just about to publish a paper on this, in that for years, we have been given women with previous blood clots transdermal HRT, and I think we are pretty confident that it's completely safe, even if you're not on a blood thinner. So.
Thank you, Roopen, thank you. And you may see as well, there's several questions both in the chat and the question about anticoagulation as well, often relating to APS. So one person has asked, I'm just trying to see it here now, that, where has it gone? They've struggled to be in a range with warfarin. They have APS and also had a cancer diagnosis earlier this year. So have then clotted through apixaban because of these complex extra risk factors. And they've now been swapped back onto warfarin. Are there any alternatives in that sort of combination other than warfarin, or for APS patients in general?
Generally speaking, if you've broken through a direct oral anticoagulant, it's the only options are warfarin or daily low molecular heparin injections. And warfarin is probably superior to low molecular heparin injections as well in that setting. So I think with APS, unfortunately, warfarin still is the best anticoagulant, though, in people because with antiphospholipid syndrome, usually we test for 2 antibodies and for 1 blood clotting test called a lupus anticoagulant. In people who have 2 or 3 of those tests positive, I think warfarin is no doubt the best agent. A case could be made in those who are single antibody positive to try a direct oral anticoagulant. So, but again, there are people who break through. And,
Thank you. Again, with an anticoagulation sort of emphasis on this. So somebody's asking that they've had 2 blood clots over a period of 5 years, one following surgery, the other following a 16-hour long-haul flight. They want to fly again, but they're worried. And they're not on anticoagulation. Is there any benefit in taking a short spell of anticoagulation before flight, or what would the general advice be? And who would they go to?
So basically, travel-related clots, public are very interested, social media interested, but travel itself in itself is a weak risk factor, and less than one case per million passengers. And okay, if you go longer than 5,000 miles, the risk is a bit more. If you're in the window seat compared to the aisle seat, the risk is a bit more. But generally speaking, the main factors underlying travel-related clots are immobility and dehydration. And so in the majority of people, common sense measures such as doing ankle exercises or making sure you get up every 2 or 3 hours and drinking plenty of water and avoiding too much alcohol should suffice. But I think in people with additional risk factors, and those are predominantly previous VTE, there's a case for giving prophylaxis. And what we've done for many, many years in our patients with previous blood clots is given them one-off injections of Clexane, for example, at the start of the flight in each direction. So I think one of the most frequently requested items from the anticoagulation clinic used to be what is called a travel letter, saying that you're safe to travel and that you're carrying these syringes to prevent blood clots. Again, this is based on absolutely zero evidence, but based on extrapolating from what we do in hospitals. So over the years, again, based on zero evidence, we have in a lot of patients, instead of giving them injections, we allow them to take a DOAC. And that's particularly, if they have previous experience of rivaroxaban or apixaban, when the clot was originally treated, then we would say to take a single dose at the start of the journey in each direction and to remain mobile and well hydrated during the journey. The only time you need more than a single dose is if you are traveling to Australia from the UK and interrupting that journey overnight. Again, with a DOAC, I think previous experience is probably good because, for example, if a woman is on a period and has never taken rivaroxaban before, to suddenly take it at the start of the flight sometimes has quite unpleasant consequences. Yeah.
Thank you. And in fact, lunchtime today, there will be a session specifically on men and, sorry, not men, on women and blood clots. So there'll be more discussion around that then. Something you also touched upon earlier and brought in a few questions around D-dimers. Now, we know they're essential, or they're used frequently in seeking or helping to gauge whether you scan, etc. But also they can give false positives and false negatives. And so there's a couple of questions about how useful is the D-dimer test following surgery. And somebody who actually had egg retrieval and their D-dimer was very high and the doctor thought they might have a PE, but it's not clear whether they did, but how useful are they when other things are also going on? Could you explain a little bit about a D-dimer?
Yeah. So the D-dimer is the smallest breakdown product of a blood clot, but generally anything and everything puts it up. I mean, we use it in a very niche area in that we know that if your scoring for DVT or PE is low and your D-dimer is negative, we have 99% confidence that you don't have a new clot. But everything else can put up a D-dimer, being in hospital, running, infection, surgery, hormonal treatment, so that stimulation for egg retrieval almost guaranteed to put the D-dimer up. Major surgery, the D-dimer will be raised for 4 to 8 weeks after the surgery. So its utility is zero in those kind of settings. So in a very specialized setting, it's useful, but outside of that, it is overused and misused.
Thank you. And then a couple of questions around understanding provoked and unprovoked clots. and whether there's a difference with them. So one person is asking about if a clot's caused by a health condition compared to one caused by a single event such as VIT, or somebody when they're unsure if it's provoked or not, but then the person does have a diagnosis of cancer. How can they find out, or can it be suggested if a clot was provoked or is clearly not provoked?
Yeah. So I think there's a spectrum, from the clearly provoked, like, major surgery of someone newly diagnosed cancer. I mean, it provokes the blood clot, and the risk of recurrence with surgery is low, but cancer clearly, if someone has cancer-associated thrombosis, we would usually continue the treatment whilst the cancer is active or they're receiving treatment for the cancer. So it depends whether the risk factor is temporary or persistent. And there are some background risk factors that can increase the risk, such as generalized immobility and being bedbound, or obesity, for example, that are particular to the patient. And so unprovoked, in the pure form is that you are minding your own business and it just comes out of the blue. And you may have some kind of background risk factors like being a bit overweight or a bit sedentary. So those are not seen as provoking factors. And there's always controversy around hormonal treatments like the combined pill. Generally speaking, based on recent studies, I think the pill is now considered, medium kind of strength risk factor, and but it's certainly treated as a provoking factor. And to women who develop the clot on the pill, we would give the option of stopping after 3 to 6 months. So, yeah. And vaccine-induced thrombosis, thankfully, is something very much of the past. And COVID-related thrombosis is also, thankfully, very much of the past. And, COVID-related clots, in the first wave with the early strains of COVID, we were seeing 3 times as many blood clots as usual. But with the newer strains, there's no strong association with blood clots. Again, vaccine-induced thrombosis was, particularly with the AstraZeneca vaccine, which is no longer in use, very, very tragic, and something that we were completely unaware for the first 1 or 2 months. But I think that AstraZeneca vaccine is not used anywhere now. And certainly back then, we stopped using it the moment we became aware of this very unusual condition. So, yeah.
Thank you, Roopen. I'm aware we've used time, but just in the last minute, obviously, the vast majority of people who develop a DVT recover well and go back to live a full, active, healthy life. But it's worrying during the time, and it's finding how long that can take to recover to perhaps sometimes a new norm, but to one that you're enjoying a good quality life. In summary, could you, there's several questions around how long this might take. Can you just summarize what helps us to recover in this journey, even if it takes 3 months or 18 months? What are those things that can help us recover after the diagnosis of a blood clot?
Yeah. I think first and foremost, it's a very individual journey. And if you are experiencing things and the body is telling you things, then it's perfectly normal. And it's perfectly normal to be, anxious or depressed and, suddenly being burdened with a new health issue. So most people are able to process that. So if you're having difficulties, then you should certainly seek support in the first instance with whoever was looking after the thrombosis. But I think there's now very good groups and then other avenues for psychosocial support as well, including, I think, Thrombosis UK holds many of the strings leading to those kind of avenues. So I think each person has to take the journey for themselves. But I think for the majority of people, within weeks and months, you do reach a new norm.
Perfect. Thank you so much. Unfortunately, we are out of time. I think we've all been there looking at so many comments and questions coming through, but also all the comments saying how good and thank you for this presentation. It has been filmed, so it will be made available within the next 12 hours within the platform. And if there were some questions we couldn't get to, or they're burning questions, if you want to email in to either Jo at Thrombosis UK or Claire at Thrombosis UK for the general questions, we will try our best to get back to you with some information around it. But for now, thank you so much to everybody who joined, and thank you so much, Professor Roopen Arya, for this very informative and reassuring session.